Today in our armamentarium, we have quite a few new instruments, high-tech instruments which are available.
No problem.
And very often the question which comes to our mind is, are these real tech gizmos? Are these real something which the trade is pushing us into? Or do they have any great advantage? There is one such tech gizmo which I would like to talk about today, is the image-guided surgery in cataract surgery. So I would be speaking on the image-guided surgery. Is it a hype or is it really worth the hype? Get your laptop. It's already loaded on your laptop.
Yeah. Introduce Nitin. Nitin. Yes. Hi everybody. We have the course master here, Dr. Nitin Balakrishnan. He is not only a wonderful surgeon, but I think he has a very scientific mind. That's why he takes the most complex talks every time. So let's look at what he has to say about image-guided cataract surgery. Or image-guided systems, yeah.
So with the advent of new state-of-art IOLs, premium IOLs, which we all have been using in our practice, one thing we have to ensure is that we are bang on target as far as the axis placement goes, as far as the centration of the IOL goes, or else we'll end up leaving a very, very unsatisfied patient. Now, in case of toric IOLs, one needs to see that our pre-op axis marking is perfect, because we all know that there is a lot of cyclotorsion which occurs, and in some cases it can be as much as 15 degrees from the sitting position into the supine position, and this can almost totally negate the effect of a toric IOL. So this pre-op axis marking traditionally is done with a marker, either a freehand marker or on the slit lamp, and this is done with the patient in the sitting position, but these are all filled with errors. Now, as you can see here, if the slit lamp beam is either above the pupil or below the pupil, doesn't go through the central Purkinje image, you're bound to have a wrong 0-180 marking. At the same time, when you're marking with a pen, very often you have thick markings. And these thick markings, as peer-reviewed literature has also proved, these thick dots can cause variations in the implantation axis of as much as 5 to 7 degrees. The bubble marker also is riddled with the same problems. The only thing, the advantage of a bubble marker is that at least you're keeping the marker in a horizontal position. We have quite a few smartphone apps like the Tor Axis or the Tor Easy, which is being used, but again, one needs to point out that it uses the gyrometer of the smartphone. But in these, the main problem is the surgeon or the person doing these measurements or doing these markings have to have a perfectly steady hand, and a little bit of movement here and there can again cause a variation in the axis. Now again, on the OT table, there are manual markers available. Again, thick dots over here can result in a wrong placement of the IOL, especially a toric IOL. So in today's era where we plan everything, our travels are planned, including our meals are also planned, then I think why not have our cataract surgery totally planned? So the image-guided systems which are available today basically are from the Varion image-guided system and the Callisto from Zeiss. I have no financial interest in any of them. But since I have been using the Varion for more than 5 years, I'll restrict my talk today to the Varion image-guided system. So the Varion image-guided system consists of 3 modules: the data acquisition module, the planning module, and the image-guided map, the OT module, where you have an overlay into your microscope. The data acquisition module images the eye in such a way that it images the scleral vessels, the limbus, as well as the iris. And this creates a unique fingerprint of the eye, which is used for registering and tracking the eye. So even if the eye is moving, even if the patient is moving the eye, the tracking takes place all through the surgery. Reference images here help us to overcome the cyclotorsion of the eye when you go from the supine sitting position to the horizontal position. The keratometry is done by the measurement unit, and this is done. Two things it does is, one, it calculates the spherical power with the help of the 3 infrared LEDs, and this is measured in the central zone of 0.8 to 1.2 millimeters with over 900 corneal reflections. At the same time, the corneal cylindrical power is calculated with the help of these 12 white LEDs in the still position, again in the central 2.8 millimeters zone with 60 corneal reflections. So as you can know, it's a high-tech device. It measures plenty of more points than a routine keratometer. At the end of the measurement, what you get over here is the entire data, which includes the limbus to limbus measurement, the pupillary size, the steep axis, flat axis, and then we have the chance to see whether all these are in the green zone like you can see over there, and then either accept or reject these readings. So what are the advantages of the keratometry when done on the Varion? So this can be used in cases of bad corneas where other keratometry methods are not reliable, like post-operative, post-keratoplasty, pterygium with a corneal scar, or in cases of post-RK. At the same time, with the help of the Varion, you can have 3 different centers which can be measured. That is the center of the limbus, the center of the pupil, and the most important being the center of the visual axis, because that is where the placement, especially of a multifocal IOL, is very, very important. Now this data is then transferred to the planning unit, and in the planning unit you have a chance to compare the various keratometries either by your which you have fed in from your biometer like a Lenstar or IOL Master, and compare the other Varion readings. It also has a chance to select whether you use an optical biometer or an ultrasound biometer. At the same time, you can fashion your incision size, so you can keep changing your incision size and the location in order to reduce the post-operative residual error. So you can keep moving the incision during your planning. So you can keep moving it to get the least astigmatism even if you're not using a toric IOL. At the same time, so the wound construction can be planned. There are a host of inbuilt IOL power formulae which are available and for us to choose. Now the most important thing is the IOL power selection can be done based on the post-op refraction. In our normal routine biometers, what you get is only the spherical equivalent. Here you can know what the approximate post-op refraction would be. So in case you're not using a toric IOL, you're leaving behind a minus cylinder, you can err on the side of a little bit of hyperopia in the spherical power instead of the routine myopia in order to compensate the cylinder in the form of a spherical equivalent. Again, the planning station can be used for post-refractive IOL power calculations, and there are for various ocular conditions it can be used. At the same time, it has got the mode for phakic as well as pseudophakic eyes, and for in the bag or in the sulcus placement. Again, there's a whole list of lenses, and the customization of the A constant is possible over here. So either you can use the company A constant, or by feeding in your post-op data, you can get in your personalized lens constant, which every surgeon can use. SIA optimization, that is a surgically induced astigmatism optimization, for each surgeon, normally we would send all our data to the Warren Hill SIA calculator. But here this can be done on the Varion planning station itself by feeding in your post-op data, and it gives you what is your surgically induced astigmatism. It can be used to plan the number of arcuate incisions you want to make in case of an LRI, the depth of the arcuate incision, and the extent of the arcuate and the placement.
Are transferred from the
The data from the planning station is then transferred through a pen drive into the OT module, which is then creates an overlay into the microscope. So you have an overlay for the incision, you have an overlay for the capsular rhexis. As you can see here now, you can have a plan. Everything is pre-planned before you enter the theater. So your side ports, your main ports, everything is pre-planned, and you can have the exact position of your capsular rhexis. So you can plan that the capsular rhexis is bang on the visual axis. You can choose it to either have it on the visual axis or on the pupillary axis, but most of the times we would choose it, and you have a continuous overlay So you can track and you can vary the size of your capsular axis. So you can have a 5 millimeter or a 5.5 millimeter, whatever you're comfortable with, and then see to it that your capsular axis is almost perfect. Again, you have a toric axis overlay. Now here, what is most important is the overlay gives you, the axis placement gives you the entire horizontal line across the whole cornea. When we do the marking with a pen, we are just marked these two ends and we are not having a line across the whole cornea, and this is where the exact placement of the IOL comes into play. Again, it gives you a guide for IOL centration and for finalization of the position of the lens. So this is a small clip. You can see here now, this is the toric marking on the lens. It's a panoptic toric, no financial interest again. And you can have a perfect placement of the lens along the guided axis, and at the same time you can then check for the centration of the lens. So you can, the crosshairs here are showing the exact center or the visual axis which we wanted to do. At the same time, people who are using the Lens 6, the Varion can also be coupled with the Lens 6 and thereby giving better results even for the Lens 6 users. So in conclusion, well, though it is expensive, it is a tool which really helps to take your surgery to a different level. And the accuracy and the perfecting the vision, what we can give it to our patients, especially the premium IOL patients who desire the best, this is something which you can do with the Varion. So I would think that it is definitely not a hype. It is definitely a tool which is useful in today's era.